Αγαπητοί συνάδελφοι και φίλοι, καλησπέρα σας. Είμαστε μαζί με ένα καινούριο μάθημα της συνεχιζόμενης ενημέρωσης στην νεογνωλογία. Σήμερα θα μιλήσουμε για ένα πολύ ενδιαφέρον θέμα για τους νεογνωλόγους, το POCUS Υπερηχογραφία Πνεύμονα. Ξέρετε ότι είναι ένα θέμα που είναι πολύ ανήκει στα hot topics τελευταία χρόνια. Έχουμε προσπαθήσει να προχωρήσουμε λίγο παραπάνω στα μαθήματα στη νεογνωλογία και έχουμε βάλει και ομιλητές από την Αγγλία. Οι 3 στους 4 βέβαια είναι Έλληνες, αλλά ο 4ος είναι ο σημερινός ομιλητής, ο οποίος θα μιλήσει βέβαια αγγλικά, έτσι. Αλλά νομίζω ότι είναι πολύ ενδιαφέρον το θέμα και επειδή ασχολείται εντατικά, γι' αυτό και το βάλαμε. Και θα τη συντονίσει ο κύριος Δάσιος, που δούλευε μαζί του στο King's. Τίο.
Ευχαριστώ πολύ, κύριε καθηγητά, για την εισαγωγή και ευχαριστώ και όλους τους φίλους και τους συναδέλφους που συμμετέχουν απόψε στο πρόγραμμα. Θα συνεχίσω στα αγγλικά αν είναι εφικτό. So, thank you all, ladies and gentlemen, for joining this session tonight. It's an education session on lung ultrasound and point-of-care ultrasound of the lung. I have the pleasure to introduce Dr. Mahesh Nanjundappa, who is a friend and ex-colleague from King's College Hospital in London that has done some work on lung ultrasound, and I can say that he's very proficient in performing clinically lung ultrasound. So thank you very much, Mahesh, for joining us tonight. The floor is yours. Thank you.
Thank you, Gabriel and Theo, for nice introduction. Thank you very much. Kalispara. Good evening, all. I'm Mahesh. I'm one of the neonatal consultant at King's College Hospital. And today I'm just going to talk about some basics of point of care of ultrasound of lungs. I'll start sharing my slides. Yeah, so hope everyone can see. So this is the place where I work as a consultant neonatologist, and I've got special interest in cardiology and lung ultrasound. I do echocardiogram as well and lung ultrasound, and I have nothing to disclose. And so my overview of my presentation is why we have to use lung ultrasound, and then I'll just briefly talk about how to scan lungs, and then some normal appearance of a normal lung, and some abnormal lung findings on the lung ultrasound, and then I'll take any questions. Please feel to ask questions. I won't be able to see on the chat. I think Gabriel and Theo will inform me about any questions as I go. So first of all, why we have to use lung ultrasound? As you all know, like chest X-ray is the first mode of investigation, but we all have seen in our clinical practice that sometimes ordering a chest X-ray for any scenario or any condition, it takes about some time, because we have to order, and then the X-ray technician has to come and take the X-ray, and there is always a risk of a radiation exposure, because you have to see the response to the treatment, and during the stay they will have multiple X-rays, and that will cause radiation exposure. And sometimes some of the conditions like consolidation and chronic lung disease changes will take some time on X-rays. And also we've all have come across in our practice that there's sometimes the babies move and there's rotated and we get sort of a lot of artifacts which we can't interpret wrongly, and then we end up taking a repeat X-ray. Whereas the lung ultrasound is catching up, and it is very quick and it's portable, and you can use your ultrasound machine which you're using it for heart and head scan. The same lung ultrasound, the machine can be used as lung ultrasound, and it's very quick, portable, and it doesn't have any radiation. And the technique is the learning curve in doing lung ultrasound is very quick, and easy technique, and can be repeated to assess the progress, because sometimes when I'm on attending, I see some condition like collapse and things. I don't tend to repeat. I just do a repeat ultrasound just to see the lungs have opened up. So it can be repeat to assess the progress of the condition. So that's why it's beneficial, and it acts as an adjuvant to your existing investigation to know your treatment. And also there's lots and studies have come up to show that lung ultrasound is quite sensitive and specific in identifying pneumothorax, pleural effusion, because we have seen many times in our own practice that we have treated as consolidation and turned out to be an effusion. So it has got higher percentage of sensitive and specificity and sensitivity than chest X-ray. And also consolidation, sometimes it's very difficult to say it's a consolidation or pneumonia, whereas lung ultrasound on chest X-ray, whereas on lung ultrasound it's quite specific. And I see whenever I do a heart scan, I always see the pattern of lung changes. So, and it correlates with the clinical condition as well, and pulmonary edema as well. So you can always differentiate cardiogenic edema or it is due to chronic lung disease changes with lung POCUS. Whereas in chest X-ray, you can just clearly say it's quite hazy, but you can't say whether it is due to cardiogenic or it's due to lung changes. So and the studies have shown this high percentage of sensitivity for lung ultrasound. And also where we have to use lung ultrasound as an adjuvant. So you can see any ventilated child with increasing respiratory distress, or in a collapsed child. Nowadays, more and more units are using for as one of the workup for a collapse or sudden deterioration, lung ultrasound, POCUS of lung and heart and abdomen as well, or you can use it for whenever there is a hypoxia or worsening of gases in a shocked child, and also to confirm the ventilatory associated pneumonia or VAP. And it's got more specificity with pneumothorax. You can quickly rule out whether it's pneumothorax or it's just an artifact, and you can tailor your treatment as well. And nowadays, I've not used, but they are using it for endotracheal intubation confirmation as well. And also you can do ultrasound in the same ultrasound, lung ultrasound. You can also look for the diaphragmatic movement and assess the extubation criteria as well. And there are lots of papers have submitted, been published about use of lung ultrasound and diaphragmatic movement and extubation. So these are the common scenarios where you can use. And how to scan lungs. As I said, the learning curve is very, very quick, and you just have to and I can say by my personal experience, I've just been trained by one of the course run by the Kings, and after that I started doing I've always do heart scan, and then I started doing lung ultrasound as well. So I can say from my personal experience and the others' experience as well, it is very easy to scan. So obviously we need to have a proper how positioning is very important. Obviously this picture shows an adult scan, but then most of our babies are in an incubator or in a cot. So you just have to adjust, make the baby positioner machine so that you could see while you scan. Position the patient. I don't do prone scanning posterior lungs. I just do anterior and lateral. So I always make patients who are most of them are ventilated. So I use supine position in the incubator or on the cot. And you also have to make yourself appropriately positioned so that you can see you can scan and also interpret the images. And as as a neonatologist, the thermoregulation is very important. So you just have to make sure you're not exposing the baby too much that it gets cold. So temperature is also very, control is very important. And then machine. So I think there are now, for this machine, for the lung ultrasound, you don't need a fancy one. You can still use the old one, which has got a 2D or M mode thing. It doesn't need Doppler or high tech. So you can still use the old machine. But there are now in the market, there are quite portable machines also are available with handheld devices as well. So you just need to have some sort of the technician can adjust to a preset to lung ultrasound, and always you have to make sure you enter the patient details and use the correct probe and ultrasound gel, and the depth should be adjusted so that you concentrate on the, I'll be talking about the anatomy of the lung ultrasound, where you need to adjust at least between 3 to 4 centimeters of depth. And also gain, you need to adjust the brightness so that it's the main bit is the pleural brightness is appropriate. So you need to adjust your gain, depth, and correct probe. And choosing a probe is quite important as well. So in general, we have these 3 types: phased array probes, which are mainly used for cardiac and neonatal head ultrasound. Linear is the one which we, or there are again different types of linear probes. The one which I use, and most of the units use, the hockey stick one. These are high frequency probes which are quite specific for superficial structures, especially for the lungs and the vascular structures as well, which and there are, again, it's not necessarily not this, you don't have to use only this one. Any sort of linear probes, you can use it. I've used even which is quite longer ones, but for a neonate it will be too big, so I normally use the hockey stick one linear probe. And you can still use curved probes as well, but these are more specific for deeper structure like abdomen. But in bigger in pediatric population, they still use curved linear probes, which has got a good penetration to the deeper structure. So this is, you need to use appropriate size probes, and then you need to have a sequential scanning. And there are different types of protocols they use in various units. They use, as I said, anterior, lateral, and posterior as well. But because our patient population are quite sick and they're quite ventilated, and they're very sick patients, so I don't tend to do posterior scan. So I tend to stick to between the parasternal and the anterior axillary line, and between anterior axillary line and the posterior axillary lines. So I normally scan these 4 areas as named 1, 2, 3, and 4. And then simultaneously you have to do it on the other side, and each time you have to label it. And also this is another nice slide picture showing where to scan. So that is on the right side between the anterior parasternal to anterior axillary line, and the same side on the left lung, and then in the lateral side between the anterior axillary line and between the posterior axillary line. And this, the bottom picture is, this is the common normally I use 6 areas, but some centers use 8 areas as the probe sites. So number 1, 2, 3, 4, and you should do simultaneously to the other side as well. Yeah. And then positioning, probe orientation. So you should use ultrasound placed longitudinally. As I said, this is one of the linear probe which I use, and this is the hockey stick commonly used. And the pointer held perpendicular to the skin, and the marker, each probe has a marker, and it has to point towards the head, patient head. And and it should be stationary, and you have to still, and once you acquire on one position, you have to move to the lower end, as I showed in the previous slide. So once you do the upper end, then do the lower end, and then go to lateral, and each site you have to label them. Yeah, it's up. And then before going into the proper normal structure, so this is a pictorial representation of how the lung scan is obtained. So the top one is where the probe site is at the skin, longitudinal, and this is the head end, and this is the foot end, and superior and inferior. So you always, the probe comes in contact with the chest wall, superficial subcutaneous tissue, and then these are the intercostal space, and then between the ultrasound, subcutaneous fat is a good medium for transduction of the waves. Then but ribs are very poor wave conduction, so highly refractive, and they give a black shadow, which we'll talk about it in future slides about how it appears on the lungs, on the ribs. And then once the wave travels, it hits the pleura, which is parietal pleura at the top, and then the visceral pleura at the bottom, which is about 0.5 millimeters in size, and they are highly reflective, and they transduce waves, and then the waves doesn't travel through the lungs because its lungs are filled with air. So the normal conception is we'll see whatever is happening in the lungs, we can see it. Unfortunately, because of the waves doesn't travel in air, so you don't see any lung inside. But based on the reflection of the pleura, we can know the pathologies of the lungs. Yeah. And then the few things you need to consider is as I said, whatever the pattern arises from the pleura, that's how you can recognize the pathologies. And always it is important to adjust the gain or the brightness so that the pleura appears bright, so that you can capture more information. And whatever the pleura, as the light, the sound waves travels through pleura, it creates the artifacts, and based on the artifacts you can interpret whether it's a normal, abnormal, or pathologies. And usually we use two modes. As I said, you can use a simple machine which has got just 2D mode and M mode. You don't need any Doppler, color Doppler, anything like that for this sort of lung ultrasound. And always the concept, we all know, air rises, it is superficial, and the fluid goes posterior lateral, and it goes and falls down. Yeah, so that concept is quite clear. And the probe should be always, the probe indicator should be always pointing towards the head of the patient, so that we get similar, anybody who's interpreting know that how its scan is done. So this general consideration has to be taken. And then we'll talk about how the lung appears. So when you place the probe on the skin, then first thing you'll see, as I said, it is subcutaneous tissue, and then you'll hit the rib. As I said, rib is a poor conductor, so the sound waves doesn't travel, and that's why you get a black sign. Yeah, and this is the subcutaneous tissue, and then the sound waves travel, and then it's the pleura, which is bright line here, which is both visceral and the parietal pleura. And then there is a thing called, as in lung ultrasound, you get a bat sign, or because the rib gives the wings of the ribs, wings of the bat is the reflection of the rib, and the body of the bat is where you see the pattern of the pleural reflection. So that's why it says a bat sign or bat wing sign. So this is what you see. So this is the reflection of the ribs and the pleura, and then the reflection of the pleura is what we see symmetrically. So these are called A lines, which I'll talk about it later. So this is how the normal lung ultrasound in a normal lung, which is filled with air without any pathology, looks like. So first thing you need to always start with is look for the rib shadows and the pleural line. And then you'll get the bat sign or bat wing sign. Then I'll show you the video how a normal lung looks like. So you can see this is the pleural sliding or pleural line. As the lung moves, the pleura also moves. So you can see that the pleura is moving. That's called it's lung sliding or pleural sliding, we say. That's always, you should start with that. And these black shadows are the reflection of the rib where it doesn't transmit the ultrasound waves. And these are A lines. It's just the reflection of the pleura, and they are equidistant. They're the horizontal lines. It's just the reverberation artifact, which is the reflection of the pleural lines, and they are called A lines, and they go symmetrically. And this is a normal lung with a normal movement of the lungs. It's called as pleural sliding or lung sliding. So you just need to understand this concept, that is pleural sliding, A lines, and this is a normal black lungs which is filled with air without any pathologies. Yeah. And other thing is this is the 2D motion and then 2D picture. And now M mode is the motion mode used to measure the movement of the given structure against time. And usually M mode is used to confirm the presence of the pleural sliding or lung sliding. So how do you get it? So this is the normal, in a normal lung, when you put your ultrasound cursor along the pleural line and press the M mode button, in a normal lung, you get this sort of picture. This is the sort of standard horizontal line. This is about the this is about the subcutaneous tissue, and this is the pleural line, and this is sort of grainy picture is the movement of the lung, and it's called seashore sign on the M mode because people somebody named it seashore sign because the horizontal lines of the subcutaneous tissue is the waves of the sea, and the sort of grainy structure of the lung movement or pleural sliding is as the sand. So that's why it's called, M mode of the normal pleural sliding is seashore sign. That's how it appears. So that's why it's called seashore sign. So you should see this sort of sign with a horizontal line and a grainy structure bottom of the lung sliding, and that's a normal pleural sliding. This is very important to understand because in pneumothorax you won't see this seashore sign. You'll see it's something different, what we call as barcode, which I'll talk later. So it is so far I've talked about and this pleural sliding is very important. If you see the pleural sliding or lung sliding, it rules out pneumothorax. So if you're worried about pneumothorax, and if you see a pleural sliding on a lung ultrasound, it is unlikely to be pneumothorax. Absence of pleural sliding is less useful because you can see in pneumothorax bronchial occlusion of various causes like clot or foreign body, severe pneumonia in a very consolidated lung, you can see absent pleural sliding, or and pleural adhesion also you can see absence. So, but the presence of pleural sliding, it rules out pneumothorax. So you can clearly say that it's not a pneumothorax. So I'll briefly talk about A lines. As I said, A lines. After pleural sliding, the next thing you need to see is A lines. A lines are the reverberation artifacts from the pleura, and they are horizontal and they are equidistant from the chest wall. So they are equidistant, so they are symmetrical, and they are called A lines. And this is quite in a normal, you see in a normal lung without any pathology, with a black structure, with the horizontal lines, they are A lines. So just to summarize, in a normal lung, you should see normal pleural lines with a bat wing sign. As I said, the wings of the bat are the shadows of the ribs. Then you should see A lines and a lung sliding. And if you put a M mode on the lung sliding at the subcutaneous at the intercostal space, you should see a seashore sign, which is horizontal line at the top and the greeny structure at the bottom of the lung movement. So these are the normal key signs of in a normal lung. Yeah. Now we'll talk about abnormal lung ultrasound findings or appearance. The first thing is the B lines, or they are also called as comet tails, or it's also a reverberation artifacts, and they originate from the pleura and they go down in a vertical fashion. So here is a picture of so this is sort of B lines. There are multiple B lines which is perpendicular, and they obscure, and it's an indication of interstitial fluid, and they are pathological, and they obscure. Again, I'll show you, they obscure. So you can see some of the A lines, horizontal A lines, but because there are multiple B lines, it's obscuring A lines, and they extend to the end of the viewing area, till the end of the how much our depth you have exposed, that will till, and it synchronizes with the lung sliding. Yeah. So these are the multiple B lines, and these are pathological. One or two is fine, but if it is getting increasing in B lines, that's pathological. That is more of interstitial fluid or inflammation happening in the lungs. And then this is again a still picture of a lung which is due to edema, pulmonary edema, or due to the chronic lung disease changes, which you can see a pleural line, subcutaneous tissue. You can see homogeneous white appearance. That's because of multiple B lines joined together to give a sort of whiteout lung appearance. This is what you see in a babies with RDS, or in a babies with chronic lung disease. This is what I see in a baby with a hemodynamically significant PDA, which is flooding the lungs. This is the common picture I see in my practice. That's because it's got multiple B lines, and you can see some of the black shadows of the rib. So that's the rib shadow. That's because of the ribs. It doesn't transmit the ultrasound waves. And again, this is just to show you multiple B lines originating from the pleura, and it's obscuring A lines, and it moves with the lungs as well. And then, as I said, in a normal lung, you have a very black with very less B lines, and it's got more air. As the B line increases, the air decreases. So this is in the second slide. You can see there's a mixture of black and white. So there are some B lines. So that means it's mild to moderate interstitial edema. And then you can see the third picture is severe interstitial edema or alveolar edema, because it's multiple B lines joined together, giving a whiteout appearance. And this is what I see in a baby with severe BPD or hemodynamically significant, or in early stages you can see in a baby with RDS. And in the last one, is in a baby with this consolidated, severely consolidated. You can see gray appearance of the lung, and there's a bit of pleural effusion as well. So this is, so as the whiteout increases, you can see that it's poor sign, and and this is what I see in the clinical practice. They are always, these sort of category of babies are always ventilated with high oxygen requirement and high ventilator requirement, whereas this, you see, it's very, they are in the better shape. So B lines are pathological, and they represent interstitial syndrome like fluid or inflammation, and you can always correlate with cardiac signs as well. If the echo shows hemodynamically significant and there's multiple B lines, so that indicates that it's due to the cardiogenic cause. Whereas in a baby with, there's no PDA but the baby is still ventilated, then it is due to interstitial syndrome, due to BPD, or due to consolidation, which we'll be talking up later. So this is B lines. Then again, as I said, it's nowadays more and more units are using pneumothorax to diagnose a quick bedside test for along with other technique that light, cold light and things. You can use ultrasound as well. So as I said, it's got a barcode sign. As I said, in a normal lung, you should see a normal lung sliding or pleural sliding, which should, when you put an M mode, you should get that seashore shown as a seashore sign, which I showed with a horizontal line and a grainy sign. But when in a pneumothorax, because of pneumothorax, the lung sliding doesn't happen, or pleural sliding doesn't happen. When you put a barcode, when you put a M mode in a baby with pneumothorax, this is the pattern you get on the M mode. So you can see whole of the M mode is sort of horizontal, or what looks like a barcode or stratosphere sign. So it just represents a sign, like it's called barcode sign because it's just represents like a barcode. So that's why you've seen a seashore sign, which is normal, and in a pneumothorax, you'll see barcode sign. And then this is another picture where when a baby is suspected of pneumothorax, when they did then M mode, and this is what you see on M mode as compared to a normal lung, which has got seashore, whereas here you get barcode sign. And this is an example of, so you can see this is a normal lung, whereas this is abnormal lung, which doesn't show. I'll show again. So you can see a normal lung with normal sliding, pleural sliding, whereas in a right lung, you can see hardly there is any movement. Yeah. So this is an example of a left lung, which is normal sliding with A lines. And this is a right lung, which didn't show any lung sliding. And when you do M mode, you get a barcode sign on the right lung, whereas in the left lung, you'll see seashore sign with the horizontal line on of the soft tissue and the lung movement, a grainy structure. Whereas in the right lung, because of pneumothorax, the lung is not moving and pleura is not moving, you'll get whole picture as a barcode. Yeah. So that's classic of pneumothorax. And then other important feature of lung point of pneumothorax is lung point. So as I said, air is always on the top. So sometimes when the probe comes in contact with a collapsed lung and a normal lung, you get a different picture, as you see in this video. So you can see on the left side of the picture, the lung is moving, whereas on the right side, it's not moving. So that's because it's coming in contact with a point where there is air and a normal lung. So this is quite pathognomic of a pneumothorax. So you can see lung point. So this is the lung point where a normal lung and a pneumothorax is meeting up. So that's quite pathognomic of pneumothorax. So in evaluating pneumothorax, if you see a lung sliding, B lines, and lung pulse, which I'll talk, which is where lung becomes like it synchronizes with the heartbeat. So if you see all these three signs, then you can 100% rule out that there is no pneumothorax. But if you see a lung point, it always confirms pneumothorax. It rules in pneumothorax. Yeah, and also there will be no lung sliding in pneumothorax, and additionally you will see lung point. So this, it can confirm pneumothorax. And then few things about how to confirm and what changes you see in effusion and edema. Pleural effusion, it always appears as hypoechoic, black, and the visceral pleura and parietal pleura are separated. And you can see a floating lung in the fluid, or a squid sign where it's like a quadrilateral, quad sign they say. It's where you can see a sort of quadrilateral area. And you can always differentiate simple and complex pleural effusion. With simple, you just see a black area, whereas you can see debris or sort of septated in complex effusion. And you can also sort of quantify as well. In pulmonary edema, it will be hyperechoic or white, which I showed earlier, and there'll be lots of B lines. Sometimes you can see in a severely stiff lungs, you can see air bronchogram, or a lung which appears like a liver, or it's called as hepatization of lung in severely consolidated lungs. And the pleura can be sort of broken down, and that's called as shred sign. And lung will become so stiff that it sort of beats with the heart, and it's a lung sign. So which is all signs of edema and atelectasis, which I'll be showing later on, later slides, pictures. And one of the key things what I have noticed is the pleural effusion is quite sensitivity of identifying pleural effusion with lung ultrasound is phenomenal. For that, you need to be you should be very specific with the position of the probe, where you need to identify the diaphragm, chest wall, and the lungs as well. And you can identify whether it's a simple or a complex effusion. And as I said, the fluid is always sort of posterior lateral. You should position your probe in the posterior lateral area so that you could identify the effusion. You tend to miss if you're doing anterior lateral. You always have to, that's why lung ultrasound has to be done both anterior and posterior lateral as well, so to rule out effusions. And this is a picture sort of showing a simple effusion. You can see here, this is the lung which is collapsed because of the fluid. The black area is the fluid, pleural effusion. These are the ribs, and this is the costophrenic angle where it meets the diaphragm. This is the diaphragm, and this is the sort of abdominal contents. I think this was one of our babies in the unit with a sort of small effusion. This was a left-sided effusion, so you can't see liver here. So it's a gastric shadow here, and this is the diaphragm. This is the sort of rib, costophrenic angle, and this is the lung. So this is one of the babies on the unit who had a simple, which got drained with a chest tube. And this was a few months ago. There's a baby with whom we were treating as a consolidation, but when I put a probe, this is what I found. This is like the collapsed lung with the fluid here on, so sort of lateral aspect, and also on the bottom as well. So it is, I can see this is also, they say quad sign, or and when you do M mode, you get a sinusoidal, so there is a sinusoidal sign as well. You can see the lung is floating in the pleural fluid. Yeah, and this baby was successfully drained with putting a chest drain, and got better after chest drain and draining out the fluid. On the chest X-ray, I don't have the chest X-ray here, but it appeared like it's like a sort of white out, some sort of a patchy white changes. But when I did the ultrasound, this is what I found. And then a few pictures about consolidation. This is the baby who is currently in the unit, which is an ex-prem 24-weeker who's ventilated now, nearly 6 weeks old, still ventilated, and is now as chronic lung disease. You can see the pleura is not moving at all. There's breaking down of the pleura. Is what we say a shred sign, and there is alveolar consolidation. You can see air bronchogram, and this is baby's currently it's in 100% oxygen, ventilated with high pressure. I can see this is sort of diaphragm, liver. This is the right lung. This is the ribs. You can see how you can't see any A lines. It's like a whiteout with sort of chronic lung disease with alveolar consolidation. This is severe form of consolidation. You see, sorry, it's and this is a baby with meconium aspiration, which is, you can see there is no lung sliding, and you can see it's ventilated. There's sort of tissue sign or shred sign of the lungs. So multiple patchy areas or white areas. There's no A lines. There's no proper A sliding. This is again picture of consolidation. And this is one of the babies who's currently ventilated with RDS. So you can see whiteout. So multiple white line. There's no A lines. There's breakdown of the pleura in this. So this is thickened, broken down. So this is a classic hyaline membrane disease or respiratory or surfactant deficiency in first few days of life, you see. And interestingly, you can also differentiate TTN as well, because we all know in TTN you'll have fluid line and you have double lung point. You can see on the left-hand side of the video is a normal lung with A lines with normal sliding, whereas on the right-hand side you can see there's multiple B lines. So this is called double lung point. So you can see two pictures of the lung. So that is normal lung and a lung with the fluid. So this is more class, and this is the head end, foot end. So usually it's more dependent part. You see the fluid in TTN. So you can diagnose TTN on X-rays, on lung ultrasound. So in summary, so you can see in normal lung, pleural lines, A lines, lung sliding, M mode, you see seashore, pleural effusion. I said it's a floating lung, sinusoidal on M mode, and you have to see always posterior lateral aspect of the pleura to confirm pleural effusion. In consolidation, I showed a few videos where it looks like a tissue-like or shred sign where there is alveolar consolidation of the pleura. And in interstitial syndrome like chronic lung disease or fluid in the lungs due to PDA or cardiogenic shock, you'll see multiple B lines. And in pneumothorax, there will be no lung sliding. And if you do M mode, you see barcode sign, and there will be a lung point where it meets with the collapsed lung and the area of air. So this is the summary of the key signs you see in the normal and abnormal lungs. And quickly, as I said, take-home message for lung ultrasound is it's very, it's got its own advantages over chest X-ray. Always have a systematic approach, have properly placed probe longitudinally. Always have a start with the pleural line, pleural sliding, bat wing sign, A lines, and then look for abnormal signs like B lines, pleural sliding, and posterior aspects of lung posterior lateral of the aspects of lung to look for effusion. And once you start seeing the pattern, you'll be able to, you can also recognize pneumothorax as well. Thank you. These are some of the resources which I've used, like Twitter, POCUS, NICU POCUS, YouTube, and the Cactus where I did my course. And there are some useful resources as well. Open for questions. Sorry, it just took 3 minutes more than allocated.
Shall I?
Yeah.
Okay. Thank you, Mahesh, for the presentation. It was very useful and very clinically oriented. Many useful visuals and comments to take home. I have to say, personally, I am not very, as you might know, I'm not, I'm not using lung ultrasound, nor do I, know the methodology that well. And but what I have come to understand is that, as you said, there are situations when you can differentiate one from something else, like, for example, effusion from some sort of solid process. And I understand that, which is very useful. Is there a way where you can differentiate, for example, consolidation from collapse using lung ultrasound?
Yeah, exactly. That's a good question, Theo. Yeah, in consolidation, you'll have a sort of pleural line is broken down or sort of incomplete, and sliding will be affected. Whereas in a collapsed lung, it's like it's got its own different pattern. So you can clear. There will be pleural line will not be affected. It's just like it appears like a sort of liver, sort of solid organ.
I see.
So I've seen in a baby where I think a couple of months ago, where the baby was ventilated and suddenly it went up to 100%. I just did a quick ultrasound and you could clearly see that it was, compared to the other lung, it was like a hepatitis. It looked like a solid organ, whereas in consolidation it looks like a very grainy appearance, as I showed in my picture. So you can clearly differentiate collapse and consolidation.
Oh, that's very useful. And also, just another little specific question that I had, and Professor Dimitriou might agree. In Greece, there is a group of babies that present with signs of respiratory distress that are typically of older gestation. So you see, babies, 35, 36 weeks of gestation with what looks like maybe RDS, or also it might be a TTN type of picture. Is there a way using ultrasound to maybe predict the need for surfactant?
Yeah, I've noticed as well where babies have needed to go on to have a LISA surfactant or ventilation. So the key differentiating between a RDS and a TTN is, as I showed in my slide, you will have areas of normal lung followed by a B line which has got fluid, whereas in an surfactant deficiency lung, you'll see uniformity. Whole of the lung will be sort of hazy, white out. So, and most of the papers are published that they've used scoring of the lungs in sort of they do, each areas are scored based on the number of B lines they see, and that has correlated with the need for surfactant therapy, and that has correlated well with other signs as well. Like in my practice as well, I've seen, I've not mentioned to the clinician, but what I've noticed is when the lung is more hazy, and it is seen on the lung ultrasound as well, and that has those babies have ended up needing surfactant or ventilation. And a lot of papers have shown that it correlates very well with lung scoring as well.
So what is the policy? So before you give surfactant, you do ultrasound?
in our unit.
Yeah. There is a lot of discussion in Greece. Yeah.
But it can be used as an adjuvant to your existing clinical signs and symptoms, because you can see, like as in the normal practice, if you take out lung ultrasound, what normally most of us do is a high oxygen requirement with X-ray changes and worsening gas, we would give. But lung ultrasound would doing lung ultrasound would sort of predict needing of treatment like surfactant and ventilation. It adds value to your decision. So in our unit, if I am attending, because not many people do ultrasound, so it is not a standard practice, but if I am attending, I would do complete workup, including lung ultrasound, to add to my...
I'm quite old-fashioned, and we had some dispute with some, colleagues. Said I prefer, I can't see if the baby have RDS, so I can give the surfactant before to do all these kind of things. But they say, oh no, we have to do ultrasound first. Say I'm not,
But as I said, the lung ultrasound is quite quick, so you don't need much time. You just a portable machine. You can just quickly, and you don't have to spend a lot of time. It's just you compare right and left lung, and then you'll get the results.
Something. If it's the surfactant, in the X-ray, the RDS have, different, grades, according to ours.
Yeah.
So the beginning is the X-ray, it's not really conclusive. So what happened with the ultrasound?
Ultrasound is more informative, so it is more sensitive and specific as well. What I've noticed as well, and we have a POCUS group which is across UK, and everyone, we present few of their experience, and everyone feel it is an excellent adjuvant to add to your diagnosis and decision making.
Yeah, and the same with the pneumothorax. So the M mode is the same if you have a small, anterior pneumothorax. Sometimes there is a small air,
Yeah.
Anterior.
I personally, I've confirmed with a few of the babies where there's pocket of air, and we have placed the chest tube while placing the probe, and you could immediately see the response to the air drainage by seeing the lung slide. So it is quite useful. So you don't have to wait for lung X-ray to confirm that it is responded. Yeah, you can always use your clinical judgment by improving in the saturation and things. But the lung ultrasound, you could clearly demonstrate that the lung, which was not moving, suddenly starts moving to once you place the chest tube.
There's some problems with
Sorry, I lost
Gabriel. Maybe his connection will come back. No, this is very, I know also, like, just a final comment, and maybe until Gabriel also joins us again. I know it's maybe not completely a part of your talk, but I also think that it's also very useful to confirm position of lines and tubes and tips, and like it's also coming into practice a little bit more. Just a little comment from the chat. So we have excellent talk, Mahesh. In RDS, can we use ultrasound changes, example amount of B lines, to assess a response to treatment?
Yes, yeah. We've seen that before the surfactant treatment, the lung scoring, and the improvement of lung scoring after the surfactant treatment. And also, even with we can also use in a collapsed lung, you can see after your ventilation strategies and positioning of the baby, you can see the response of opening of the lungs in a collapsed lung, where you can see the changes. You don't have to do the X-ray to confirm whether the lung which has collapsed has opened up or not. So you can assess your treatment as well. And there are few studies which have published the response to the steroid treatment for BPD as well, where they have shown that the scoring before and after treatment of steroids, where the lung score has improved, and that sort of tailored your extubation criteria as well. And then few of the studies are using as a part of lung ultrasound to see the diaphragmatic movement as a extubation criteria as well, which is more in pediatric population and adult population, but it's few of the centers have started doing ultrasound a diaphragm to assess the extubation criteria as well.
Interesting. Thank you. I don't know whether Professor Dimitriou has any other comments to make, or
I don't think that there's any more questions, and the connection is not very stable.
Okay. Mahesh, thank you very much.
Νομίζω πρέπει να σταματήσουμε εδώ, δεν είναι πολύ stable connection.
Okay.
Thank you very much, Gabriel and Theo and Storius, for this opportunity. I think in Greek you say Elaritroi.
Ευχαριστώ.
Efaritrois.
It's a good try, Mahesh. It's close enough. You're welcome.
Thank you, Mahesh. So, αγαπητοί συνάδελφοι, την επόμενη Τετάρτη είναι 29 Δεκάτου, υπάρχει παιδιατρική, ας το πούμε, παιδιατρικό ενημέρωση. Είναι πρόληψη παιδικής κακοποίησης, πραγματικότητα ή ουτοπία, από την κυρία Σολδάτου. Νομίζω είναι ένα πολύ ενδιαφέρον θέμα και αφορά τους παιδίατρους και ιδίως τελευταία είναι πολύ hot topic. Και 6 Δεκάτου το επόμενο της νοκνολογίας είναι εξωματική γονιμοποίηση και πρώιμη καρδιομεταβολική νευροαναπτυξιακή νοσηρότητα από την κυρία Μπριάννα. Ευχαριστούμε που είσαστε μαζί. Καλή νύχτα σας.
Καλή νύχτα.